Distinguished field of speakers here, I feel humbled, so I don't know if I will be able to live up to expectations, but as I always say to the people in the hospital, one can only try. So what I'll be talking about is imaging in the setting of ischemia. Now, maybe some of you might have seen this article earlier this year in the New England, which brings the tale of coronary artery disease and myocardial infarction and all of the innovations that took place over the history of cardiology of the last 100 years. And you see here a lot of things happening, surgery, interventions, more interventions, studies with drugs, drug-eluting stents, but there is no imaging in there. Imaging doesn't seem to appear, and there are some reasons, I think. I don't think that we have done enough of an effort to show what the exact place of imaging is within the armamentarium of cardiology. But on the other hand, I'm sure it's the same here in Spain as it is everywhere in Europe and in the world for that matter. Imaging has come under scrutiny because medical technology is expensive. Imaging, and specifically also in cardiology, is a very large expense, and people, the providers, the public, is scrutinizing that expense and is asking us, is it really worthwhile spending all of that money? What is the evidence? What should the evidence be? If we compare the evidence that we get together to start doing things with imaging and with techniques in general, and if you compare that to what drugs have to go through before they are being launched on the market, that is a very big difference. You go to all types of trials, you have to show that you're efficient, efficacious, that you have an edge in comparison to others. In machines, you just show that you do not electrocute the patient, you get a CE label, and you can use it, period. If you look at the levels of evidence that we should really get with respect to imaging, this is the list. Technical quality, and accuracy, sensitivity, specificity, we get that, maybe not to the right comparators, but this is where we get. But then, prognosis, we have some data on prognosis, but level 4, 5, and 6 is remarkably absent. There is very little evidence to what degree imaging really impacts on patient management. There is very little evidence on the efficacy of imaging as a tool, and least of all, what does it put in respect to societal improvement? Now, if you look at ischemic heart disease, which are the targets? We obviously want to prevent acute ischemic events. We want to prevent arrhythmias originating from scar or ischemic areas and thereby preventing sudden cardiac death. And if there is a scar, if an acute coronary event does occur, we want to prevent remodeling and heart failure. Now, if you look at the evidence that we've been taught over the last 20 years, this is what everyone is telling you. We have eccentric remodeling of our coronary arteries, and at some point there is a rupture, there's a thrombus, there's an occlusion, and there's an infarction. In that same New England article, that story is repeated with like a volcano-like eruption here, with the liquid core being exposed to the bloodstream and a thrombus occurring and an occlusion. Now, I'm sure that all of you know that there are different types of lesions in the wall, the fibrous cap with the necrotic core, the thin cap which gets ruptured, and typically we say these are 30 to 50% lesions that rupture and cause these acute coronary syndromes. And these are the data that support that position, that most lesions causing acute syndromes are less than 50%. Now, if you go back to those studies, you will find that the total of patients in these studies is about 150. So actually, not that many. So is this really true? If you look at prevalence of coronary artery disease, and there's a lot of studies being done in the Korean and the Vietnam Wars, we see that even at very young age, there's a lot of atherosclerosis present. You see here some of the numbers, but they're all in the 40s, 50s, and even higher percentages. Here you see them depending on grades, and of course most of them are lower grades, and here you see the ages, but some of them are significant. And in this slide, you see that significant, more than 40% in the LAD lesions, at very young age is quite prevalent, although all of you know not many acute coronary syndromes occur in that age group. So if it is the 40% lesions that cause acute coronary syndrome, why aren't there more in that age group? So, as an interim conclusion, they're very common, but we see few acute coronary syndromes. Now, it's been said that is because there are many more of those, and so the chances of having something occur in these moderate type of lesions is more prevalent. And we've been looking at vulnerability, vulnerable plaques, and we've moved from population risks to patient risk, vulnerable plaques in interaction with vulnerable patients, and we've been trying desperately to try to characterize the vulnerable plaque and to try to do something about it. But if we really go to pathology, and what I'll be showing is quite a bit of data from Renu Virmani, then we know that most of the cases, about 2/3, it is indeed a rupture of a plaque that causes an acute coronary syndrome. But also in 1/3 of cases, there is no rupture, it is just erosion and a thrombus on top of a lesion. But if we dive a little deeper into that data, and we look at age groups and at what is causing sudden cardiac death and acute coronary syndromes, acute thrombus is really most prevalent in the younger groups, but declines with age, while plaque erosion and stable plaque are more prevalent at older age groups. So this is not consistent with the 40% lesion that causes most of the syndromes. And if we even go further and look at lesion severity, rupture incidence is more prevalent in the more severe lesions. And the think cap lesions are also similarly more present in the more severe lesions. So what pathology is saying us here is it is the more severe lesions that are more often ruptured and that are more often the cause of acute coronary syndromes. And for a very simple reason. If you have a small thrombus in an 80% lesion, your vessel is occluded. If you have a small thrombus in a 40% lesion, you might have some instability in that patient, but not necessarily a total occlusion. Notwithstanding the fact that with imaging we've tried over time to try to characterize activity in a lesion, again in that holy grail search for the vulnerable plaque, but we've done it with different techniques. But I always pose the problem today, and I'm not saying we do not need to research this, but today do we have a targeted treatment for vulnerable lesions? We all know that it's seldom that there is just one vulnerable lesion in one patient at one time. Usually there are 3 or 4 of them. Are we going to put stents in them? We'll end up with steel coronaries if we do that. So the only thing we can do today to treat vulnerable lesions is to do prevention, to treat the patient's hypertensions, lipid disorders, diabetes, etc. So I don't think that targeted treatment, again, we should look for it. We should try to identify new therapies that really are aimed at them. But today, there is no targeted treatment, as far as I'm concerned, for vulnerable plaques. So pathology shows that there are more complications in more severe lesions, and the vulnerable plaque today has no clinical impact. So how do we then tackle these patients? What do we do? What can help us in trying to identify the patients where we need to do something? Risk factors, do they help? These, the solid bars, are the actual presence of coronary artery disease on CT in comparison to the prediction in light bars here expected from one, there are many, of course, prediction models and risk factors. You see that they overestimate the actual presence and the variability is enormous. You all know it is good to identify the risk at the level of a population, but in an individual patient, it's not always helpful. Symptoms. Angina is the last step in the cascade of ischemia, and we all know that in patients with or without ischemia, but with signs of ischemia on treadmill exercise, the prognosis is the same. So a patient without ischemia isn't better off than a patient with ischemia, probably even on the contrary. Then we have new techniques, new imaging techniques, calcium score, for example. There is something to be done here because we all know that patients with a very low calcium score have a very low chance of having disease. But is it zero? No, it's not. Here you see the relation between the calcium score, and these are considered low calcium scores, and the actual presence of lesions. You see that even in the zero calcium score, there are lesions less than 50%, more than 50%, and even more than 70%. So it is not a free ticket when you have a low calcium score. And if we look at patients with calcium score of 0 and with lesions on CT, it impacts on prognosis. So it's not that even when they have a calcium score of 0, and if they do have lesions, that those lesions do not cause any problems. No, they do. Here you see again in patients with low calcium scores but with significant disease, the impact on death, in myocardial infarction, and need for revascularization is very present. Again, in patients with the calcium score of 0 and with lesions, the incidence of major events is very present there. So a calcium score of 0, yes, but it does not mean that those patients are totally free of any risk. Stenosis severity per se, which we now non-invasively can tackle with CT, I'll be brief about this. You all know the data with the fractional flow reserve, that judging a lesion doesn't tell you if there is ischemia with it. And what is more, and I think even better showing, in patients on which there was 3-vessel disease on the basis of an angio, the actual fractional flow reserve showed only 3-vessel ischemia in 14% of these patients. And 3-vessel disease being a formal indication for revascularization, one can ask oneself, what are we doing here? And even in left main disease, judging the lesion doesn't necessarily tell you if that lesion is really causing ischemia. So I think that looking at anatomy alone, again, doesn't tell the whole picture. So I think, and you saw me coming probably, we need to look at ischemia. Because ischemia can guide therapy. I won't go into this, but you probably know this, which is from all the studies, but which have been confirmed by other methods, they come from nuclear medicine, that you need about 10–15% of ischemic territory to show that revascularization brings you a better prognosis than medical therapy. So it's not just the presence of ischemia, it's also the extent of ischemia. But you will say, will it help us in acute coronary syndromes? As I've been telling you, we've now a lot of modalities that can help us non-invasively and invasively to better look at lesions. We have regular angio, coronary angio, we have luminoscopy, we have optical coherence. All of these over the last 5 years have really helped us because with this technique we can follow up patients, we can see how lesions develop, and here are just some different lesion types. They do not show too well, so I'll pass on that. From these CT data and data that show evolution over time, these investigators looked at patients who developed an acute coronary syndrome with a ruptured fibrous cap, with an intact fibrous cap, and with stable angina. What they show is, this is the lesion severity and the reference diameter. All of these lesions, if it was an acute coronary syndrome that they developed later on, if it was with or without a ruptured cap, the lesion severity at the beginning, before, is the same and is 75% approximately. So confirming again the fact that it is indeed significant lesions that cause acute coronary syndrome in the majority of patients. These are some other data. Again, it's more than 50% lesions in comparison to less than 50% lesions. It's more often those that cause acute coronary syndromes. And the study concludes that it was only the number of more than 50% stenosis lesions that predicted myocardial infarction or acute coronary syndromes. Here again, it's the significance of lesions. Another study, non-obstructive versus obstructive disease versus no on CTA. It's the severity of lesions where the patients develop acute coronary syndromes. So I think that there are data emerging that ischemia and severity of lesion is also coupled to future coronary syndromes. Therefore, I think that it is important that we identify and quantitate ischemia. Now, what method do we use? I think that there is, and that was my start off, no firm data to show that one technique is really any better than another. Here's just one study comparing nuclear techniques with echo techniques. They all score similarly. Here we also have MR, in this case for showing the effect of revascularization regionally or globally. Most of these techniques perform similarly, and there is some studies that show some evidence of better use of one over the other, but I think overall that is not conclusive for the moment. I won't go into this. We've had some discussions about is it reasonable or is it really necessary to quantify viability before we proceed to revascularization. There are some recent data again showing that if you have viability, revascularization is better. So I do think that we should also look at viability, but I won't go into that. To end up my talk, with all of these things and all of this evolution of knowledge that we have, all of the imaging that we do, and you see here the different techniques. We have CT, PET, you can SPECT and MR. We often combine techniques. If we do a CT, we also do SPECT and other things. But if we look at in how many cases where we see something significant, a significant lesion, significant ischemia on that test, how often do we intervene in these patients? 50%, not more than that. Here you see, again, no lesions, mildly abnormal lesions, moderately severe abnormal lesions, and getting the patients not to CAT, no medication change, here to CAT, and here to CAT and medication change. We do not act upon what we find. We do a lot of imaging. We look at the images, we get the results, but we don't act upon them. Not often enough. And then, of course, the providers will tell us, you do all of this expensive imaging and you don't change the treatment of the patients, then why do you do it? So I think in conclusion, I would say that it is important and most important to look for ischemia and viability, ischemia both the presence and the extent. Use the technique that you know best, if that is SPECT, if that is echodobutamine, if that is MR adenosine, and most importantly of all, act upon what you find. Thank you very much.
Please stay there. Well, the talk is open for discussion. Somebody in the audience want to?
Thank you very much. I'd like to ask you a question on your opinion on the usefulness of viability studies in patients with depressed left ventricular function after the lot of confusion that brought out the Stitch study.
Yeah, that's what I was referring to. The Stitch has supposedly concluded that viability has no place now. I think if you dive in, and we participated ourselves in the Stitch, if you dive into those data, I think there's a lot of things that can be said about it. Now, of course, it's always easy if you do a trial and it doesn't come with results that you were expecting, then you say the trial wasn't any good. So I shouldn't be doing that, of course, but I do think that there is more evidence besides the Stitch trial, and that's why I was showing that recent paper in the European Heart Journal, where it is convincingly shown that viability and testing viability, but then again, if you have no viability, you don't do anything, which often people still do. And on the other hand, I remember that many years ago, 10, 12 years ago, we had a patient with an ejection fraction of 25%, full viability. The surgeon didn't want to operate on the three-vessel disease because he said he'll die and he won't improve. We said, I think we should do it. The patient, after 3 months, had an ejection fraction of nearly 50%. It is showing cases also, which I haven't done today, but it's also by seeing that you start to believe. I do think that viability, but acting upon what you see in both instances is still reasonable to do. Robert.
Speaking about viability, I think for the surgical point of view and the cardiologist point of view, I think that we should go further than viability. I think we should go for recovery of function. So we should find a kind of imaging saying that not only there is viability, but there is a possibility to recover the function. Because if you look, for instance, we have done that when I was still in Brussels with Manoverskeld and William Wines. Viability doesn't mean that if you do something, you recover function.
Yeah.
And so I think you have to make the difference also with the imaging to be able to know we have viability, but it's not going to recover, or we have viability and it is going to recover.
I fully agree with that, and I haven't shown that slide because everyone probably knows it, the famous New England slide on viability, where you have, on the one hand, no lesion on late enhancement, 80-90% recovery, full transmural late enhancement, 0% recovery. But if you look in the middle, it's flipping a coin. Some recover, some don't. So in the protocol that we use, if we have intermediate transmural late enhancement, we always do a low dose dobutamine to show that there is recovery of function. So I fully agree with that. I do think there is one note to be made here. I think that there might be some recovery and might be a positive impact on remodeling late. But of course, the risk of surgery is there in those patients, so you need to be sure that you get over the acute phase, and then, because it won't recover function in days or even weeks, it could take months. But I fully agree, you do need to do a low dose dobutamine in those cases with intermediate late enhancement.
Hey, good morning.
Good morning.
As an interventional cardiology we have a problem to identify the vulnerable plaques. I want to know what do you think is the best technique to identify this kind of plaques?
Again, I think there are techniques, there are thermal techniques, there are techniques that try to show that there is activity there, there's nuclear techniques that try to identify inflammation, but the problem is that we do not know which plaque ultimately will cause a syndrome, and that was the point that I was trying to make, we do not have targeted treatment for those plaques. We can't go in and laser them yet, that'll come maybe, or do something to the plaque that it becomes a stable plaque that doesn't do anything. So the problem for the moment is not only that we don't know what vulnerable plaques, which are vulnerable plaques, which are active vulnerable plaques, but we don't have a targeted treatment. So from a clinical perspective, it's a very nice and very important, let's reinforce that thought, very important research area, but it doesn't have clinical impact for the moment. We give them statins, but we give all patients statins these days, and those stabilize plaques probably.
As you have shown, studies with FFR have evidence, show evidence that most of the lesions that have a stenosis, around 60–75%, most of them have no ischemia, have no FFR. Then you can do a non-invasive test, but you do not detect ischemia, but the lesion is there and it's 75%. That's one problem. Second, most of our patients coming with an ST elevation MI have no previous symptoms. These patients have no chance to have any kind of test because they were absolutely naive for ischemia, for angina, for everything. I think the iceberg of the patients shows that most of them are heading for any kind of study before this, the acute coronary syndrome. The third, prospect trial, 700 patients with acute coronary syndromes follow-up and very low rate of events. Then I think the pending problem with us is to detect the patient that is going to have the ST elevation MI tomorrow. And this patient is not a patient with PCI yesterday. It's a patient without any symptom previously or any kind of clue that you may think that this patient is ischemic. Then do you believe that maybe we have to put imaging techniques as screening tools with patients with some epidemiologic high risk, patients with diabetes, smokers with hypertension, metabolic syndromes in the 50s? Because I think that the people that is coming to the cath lab and with acute coronary syndrome and have PCI and is treated with statins, with ACE inhibitors, is not really the high-risk population now. For acute coronary syndrome, the high-risk population is not known. It's coming tomorrow.
Okay, a lot of things here, so I'll try to go through them step by step. When I was talking 75, yes, I think there is even some evidence that it is even the more severe lesions. There is some evidence that it is really linearly related to the severity, so that the even more severe lesions carry an even higher risk for developing acute coronary syndromes, but it's little evidence today. I do agree that those patients will not necessarily show ischemia. On the other hand, and I do fully agree with you that about 50% of patients are naive at the time of their acute coronary syndrome, and that therefore we haven't done anything about it. That, I think, is the major challenge that cardiology stands for today, to try to identify the high-risk patients. But we've been looking most of the time at high risk in the sense of vulnerability and little severity of stenosis. I think we might need to go more in the direction of identifying the more severe lesions and the more stenotic lesions, and therefore the more ischemic provoking lesions, and try to treat them. There hasn't been any intervention trial, let's be clear about that, that had as a target, we take lesions that are severe, we treat them, and we see if we prevent acute coronary syndromes. There's no evidence. So let's be clear. I was just throwing this out more as a discussion point than anything else. But on the other hand, saying that we need to identify 40% lesions and try to tackle them directly, I think there is fewer and fewer evidence to show that that is the way to prevent acute coronary syndromes. But we have a problem because we don't know how to identify those patients. And on the other hand, even if we identify them, we throw drugs at them, but they still develop coronary syndromes. So we're all, and I don't need to tell you that today drug development in cardiology is going that way. There's no money to be made and there's no development anymore. Most of the major companies are dropping drug development in cardiology today. So we have a problem.
One quick question, Frank. What do you think? What's your opinion about multimodality imaging? Does it add information on what already we have?
Multimodality imaging, I think that getting at the same time information about function, perfusion is valid. If you talk about multimodality using combined techniques, I would prefer to go in steps, and simply because of either the radiation burden or the cost burden. If we say we do in every patient whatever, a full SPECT perfusion study, a CT, an MR or an echo for function, etc., we get overlapping information at too high a cost. I think we need to take a stepwise approach. And in that sense, I've always been, not always, but I've been putting forward the thought that within a hospital, there should be an imaging department that looks at the clinical request. So the clinician says, I have here a patient with that history, with that symptomatology, whatever, and I want to know if he has ischemia, if he has a scar, if he has that. And the imaging department decides on, depending on a lot of things, what imaging to do to answer that clinical question. It's the same what we do with laboratory medicine these days. It's all evolving in the same way. I do not think that the technology today is so easy or so open that everyone can use it to its full extent. So we need to use the people who know that technology and who can make the choices about to do what in what sequence.
Frank, one more question. In practice today, you have a patient who is a valvular patient and is going to be submitted to surgery. You always do, if it's 50 or 55 years and older, you do always a coronary angiogram. For years, those patients who had 60-70% stenosis were revascularized, even in most cases asymptomatic, completely. Today we know revascularizing a non-ischemic array, maybe even harmful. Mm-hmm. What do you think we should do? FFR is not yet implemented in every single unit, and what's your point of view there?
I think that we need to look for ischemia again with a non-invasive technique, and that technique can be echo, MR, SPECT, whatever your department is best at. We do know that neither of those techniques is perfect today, but I think that, again, from a perspective of impacting on the prognosis of the patients, if the patient has no ischemia, then there is no need to revascularize.
Very good. Thank you.